HSP IgA is small vessel vasculitis. It overlaps with IgA nephropathy, Buerger's disease. It occurs in children following infection. Clinical features may palpable purpural rash over buttocks and extensor surface, abdominal pain, polyarthritis. IgA clinical features hematuria and renal failure. Treatment, you will give analgesia. Now these are extra points. Alcohol binging, ADH will decrease and cause polyuria. Thrombocytopenia, HUS, unstable platelet. There is no thrombocytopenia in HSP since the platelets are unstable in it. Testicular cancer, most common malignancy in men among from 20 to 30 years. Germ cell tumors, seminomas, non-seminoma. Non-germ cell, Leydig cell, sarcoma. Non-seminoma, embryonal, yolk sac, teratoma and choriocarcinoma. रिस्क फैक्टर्स में इनफर्टिलिटी होती है 3 times. Cryptorchidism, family history of testicular cancer, Klinefelter syndrome, mumps, orchitis. Tumor markers are germ cell, seminoma, HCG 20%, non-seminoma, alpha-fetoprotein or beta-HCG 80 to 88%. LDH इसमें 40% होता है. डायग्नोसिस USG करते हैं. ब्लैडर कैंसर रिस्क फैक्टर ट्रांजिशनल. स्मोकिंग 4 times. एनालिन प्रिंटिंग टेस्टाइल 2 नाफ्थेलामाइन एंड बेंजाटीन होता है इसमें. Rubber manufacturing, cyclophosphamide, squamous cell schistosomiasis and smoking can cause squamous cell cancer, bladder cancer. Okay, then AKI, pre-renal azotemia and acute tubular necrosis. How to differentiate? In pre-renal azotemia, the urinary sodium will be less than 20. The renal will contain the sodium. तो यूरिन में कम जाएगा. यूरिन का ऑस्मोलैलिटी बढ़ेगा more than 500 ml. Fractional excretion of sodium will be less than 1%. Serum urine creatinine will be more than fractional excretion of urea will be less than 35%. And urine and plasma osmolality का रेशियो जो है वो 10:1 होगा क्योंकि यूरिन का osmolality काफ़ी ज़्यादा है. Specific gravity will be more than 1020. This is of the urine. Normal or bland cast will be there. Acute tubular necrosis में सोडियम चला जाता है बाहर, तो यूरिन सोडियम will be more than 40. Osmolality will be less than 350. Fractional excretion of sodium is more than 1%. Serum urine creatinine is normal in acute tubular necrosis. Fractional excretion of urea is more than 35%. Urine plasma osmolality is less than 8:1. Specific gravity is less than 1020. Brown regular casts are seen in this case. Nephrotic syndrome के causes: primary glomerulonephritis in 80% of the cases, minimal change glomerulonephritis, membranous glomerulonephritis, FSGS will be there, membranoproliferative glomerulonephritis will be nephrotic. ठीक है. Systemic disease 20%, diabetes, SLE, amyloidosis, drugs like gold, penicillamine, others like congenital neoplasia, calcium, lymphoma, leukemia. Infections like bacterial endocarditis, hepatitis B, myeloma and malaria can cause nephrotic syndrome. Now what are the line of treatment for renal stones? You do a non-contrast CT, kidney, urine, bladder. 14 hours of admission is required. Management, you give intramuscular diclofenac. If it is less than 5 mm, it will pass within 4 weeks. If it is less than 2 centimeter, you will have to do a lithotripsy. Less than 2 to pregnancy, you do a ureteroscopy. Complex renal calculi and staghorn, you do a percutaneous nephrolithotomy. If there is ureteric calculi less than 5 mm, manage expectantly. Prevention of renal stones. Calcium stones, there is hypercalcemia in 5 to 10% in patients with calcium stones. So you have to increase the fluid intake. So low animal protein, low salt diet, thiazide diuretic, which will increase the distal tubular calcium resorption. ऑक्सैलेट स्टोन्स, कोलेस्ट्रॉल डिक्रीज, पैराडॉक्सिन देते हैं इसमें. यूरिक एसिड में allopurinol, urine alkalinization, oral bicarb will be given. Now what is, these are just randomly, okay. Anti-GBM, good pasture syndrome. This is again a small vessel vasculitis like HSP. In this there will be pulmonary hemorrhage and RPG in that. Anti-GBM antibodies against type 4 collagen is there. It is most common in men. 2:1 is the ratio between men and women. Bimodal age group 20 to 30 and 60 to 70. HLA-DR2 is involved. Clinical feature pulmonary hemorrhage and recurrent RPGN is there. Then involvement investigation, you do a kidney biopsy. In that you will get linear IgG deposits along the basement membrane. There is increase in the TLCO secondary to pulmonary hemorrhage. The increased risk factors of this are smoking, lower respiratory tract infection, pulmonary edema, inhalation of hydrocarbon and young males, plasma exchange, steroids, cyclophosphamide. Lower urinary tract syndrome, predominantly voiding, pelvic floor muscle training, moods, moderate severity, alpha blocker, anti-muscarinic, enlarged prostate, alpha blocker and 5-alpha reductase inhibitor, predominant overactive bladder, moderate fluid intake, bladder retraining. ठीक है. Overactive bladder, you have to give moderate fluid intake, bladder retraining, and anti-muscarinic drugs like oxybutynin, which causes immediate release, tolterodine or darafenazine, or mirabegron in old people, nocturia, furosemide 40 mg or desmopressin. Focal segmental glomerulosclerosis causes idiopathic. Secondary pathology like IgA nephropathy or reflux can cause it. HIV in heroin drug users, Alport syndrome, sickle cell disease. There is high rate of recurrence amongst kidney transplants. Investigation, kidney biopsy, focal segmental sclerosis and hyalinosis, effacement of the foot process of the electron microscope. Management, steroids and immunosuppressive agents. Prognosis, untreated FSGS is less than 10% and there's chance of spontaneous remission.